our first segment is kind of what is managed care? How does it fit into the Medicare program? And then talk a little bit about who's enrolled. So we'll kind of give an overview of the Medicare program, what managed care is and how does it fit into the Medicare program, who's enrolled, and then implications for the data that's available to researchers, which is probably why you're here and interested in using that. So the original structure of the Medicare program, which was started in 1966, is that we had a Part A, which is called hospital insurance, and a Part B, which is supplementary medical insurance. You'll sometimes see them referred to as HI or SMI. The hospital insurance covers inpatient and post-acute care. So the inpatient stay, and then if you need home health care after that stay, skilled nursing facility stays. It also includes hospice. And Part A is an entitlement, which means that if you qualify for Part A, then you can enroll for free. And qualification is similar to the Social Security requirement. You have to work at least 4 quarters. And then there are some deductible, there is a deductible for your hospital stay, and there are some co-payments that are associated with long stays or post-acute care. The supplementary medical insurance is instead, it's not an entitlement. There is a monthly premium. You have to sign up for it. It also has an annual deductible and co-insurance, and that will cover your physician services, any outpatient services that you get, durable medical equipment. Some drugs are available in Part B. So things that you might infuse in a doctor's office, for example, would be a Part B covered service. But not something that you pick up from an outpatient pharmacy. The population that's served by the Medicare program is primarily people over 65 and over. So you qualify, typically if you've worked your 4 quarters, you qualify at age 65. But if someone is younger than 65, but they've applied to the Social Security Administration and received a disabled designation, so they can receive benefits, they will also be entitled to Part A or entitled to Medicare. As well as some people with end-stage renal disease and ALS. So those are 2 special populations that will be covered by the Medicare program. Services that are not covered by Medicare, so long-term care, most dental care, eye exams, dentures, cosmetic surgery, acupuncture, hearing aids, routine foot care. So there are things that are just not covered by the original Medicare program as it was designed. But in terms of providers, there's very few limitations. So institutions typically apply to become Medicare certified. And then there are some requirements that they have to meet, but once they're Medicare certified, any Medicare beneficiary can go to any Medicare certified facility. Non-institutional providers, so a physician may choose not to accept Medicare payments as the full payment, or they could opt out of the Medicare program, but far and away, most physicians will accept Medicare payment, and then there's no restriction. Any beneficiary can see any Medicare physician. And there's no requirement for having a primary care provider. It's encouraged, but there's nothing that is required there. People can have Part A and Part B in combination, and that is the most common. You can imagine that you would want to have all of these services covered. The monthly premium is something that can be taken right out of your Social Security check if you're receiving benefits. And or if, there are Medigap policies that help pay for premiums and deductibles and coinsurance. So by far, most people have Part A and Part B. It is possible to have one or the other. Perhaps you have some other form of insurance that can cover these services. If you are not entitled to Part A, sometimes you can still buy into Part B. But again, the over 95%, I think is the number, but recently it may have fallen a little bit, but 90% of people are going to have Part A and Part B coverage. Now, managed care is a little bit different than that setup that I've talked about with the original Medicare. Managed care typically is an organization that manages maybe provider networks. So they contract with providers to say, will you provide care to anyone that's part of my, that is a beneficiary of mine? They may require that person, the beneficiary, goes to see a primary care provider in order to get a referral to a specialist. That's not always true of managed care, but that is the way that many of them are designed. But there is typically a provider network that is covered, and then going out of network will have different fees associated with it. Managed care also typically does some form of utilization management, whether that be step therapy, so requiring physical therapy and medication before having back surgery, just jumping into back surgery, or prior authorization. So saying, before we cover this, you need to check with us and make sure that we agree that you need the service. They may, when someone's starting to receive services, they may hook them up with case management in order to get them the services that they need in the way that seems most efficient. There is also retrospective review. So after someone has used a service, the managed care organization will be looking back and trying to decide, was that appropriate? And then there's also incentivizing care via payments. So maybe designing formularies that will incentivize use of generics, for example, generic drugs. And then they may also involve capitated payments to payers or providers. So it may be that, there's it really should be capitated payments to providers. So they may say, I'm going to pay this provider X amount of dollars to take care of this patient. They won't. It's their responsibility to do the care within that payment. They're kind of taking on the risk there. Managed care may also involve horizontal or vertical integration. So the payer may actually own a hospital that's where their beneficiaries are seen, or the hospital and the clinic may be together, and they contract with the managed care organization. So managed care has a long history. There's been, I think since the early 1900s, there have been organizations that have functioned similar to managed care. The way we think of managed care now was firmly established by the Health Maintenance Organization Act in 1973. So way back to the Nixon administration, that provided a federal definition of HMO and provided some funding for HMOs to get started, and also required that employers offer HMO health maintenance organizations to their employees. And the idea behind managed care is really that, if you're doing all of these things, hopefully you would control costs and increase efficiency. You're not going to have a lot of care that's not needed. And so that's how managed care came about. Now, how did managed care get into Medicare? There were some, I think, demonstrations prior to this, but in 1982, there was a Tax Equity and Fiscal Responsibility Act, or TEFRA. It was intended to control Medicare costs that were seen to be rising. It did lots of things, including creating DRGs for inpatient care. So instead of paying for everything that happened during an inpatient stay, they said, we're going to give you one payment, and the hospital is supposed to get all of their costs within that payment. It also created the hospice benefit in the Medicare program. But it's pertinent to our interests here. Medicare Managed Care, or Medicare Part C, as we sometimes call it, is what's established. So now we have an alternative, and the Part C is kind of an unfortunate name because it doesn't replace Part A and B. Part C is really a way of administering both A and B benefits. So this comes into play when you're looking in your data in the master beneficiary summary file. If you look for everybody enrolled in Part A and Part B, you will get both people enrolled in original Medicare and in Medicare Advantage. There's a different variable altogether that will tell you how they're getting their Part A and Part B benefits. So just describing that, and almost all plans will provide both A and B. So you've already heard me say Medicare Part C. After the Balanced Budget Act in 1997, they tried out the name Medicare Plus Choice. So you may see that. Still, I don't think it's very commonly used anymore, but you may see it. And then really after the Medicare Modernization Act in 2003 is when we kind of created the term Medicare Advantage, which is often how we use it now. Fee-for-service Medicare may also be called Original Medicare or Traditional Medicare. It's not when we say fee for service, it kind of sounds like, well, the Medicare program will pay for each item that is billed, and it's really gone away from that model for most things. But so really probably original Medicare or traditional Medicare are more appropriate names, but we do still use fee for service mostly, I think. So the way that fee for service and managed care differ within Medicare, with fee for service, CMS is paying providers directly for the service that they provide. So they provide the service and they bill CMS directly, and then CMS will pay them. The payments are based on standard fee schedules. So there's an inpatient prospective payment system. There are outpatient prospective payment systems. You can find information from MedPAC about how all of those different things are designed, but typically the provider knows what CMS is going to pay them for a given service, and we can find that out too. We can go onto the website and find out what the payments are. With managed care, it's different. So CMS is paying a monthly payment to the managed care organization, and then the plan is accepting the risk for any care that might exceed the payment. And the payments are based on the plan bid and the risk adjustment. So the plan will decide how much they think they're going to need, and the risk adjustment takes into account how much care their beneficiaries probably need based on their diagnoses. And that information goes together and it determines the payment to each plan. And it's one payment per person per month usually. And then providers are paid by the managed care plan instead. So they will bill the managed care plan, and the managed care plan will pay them. And the payments are negotiated between the providers and the managed care plan. So it's not something you can go onto a website and find out. By and large, that's proprietary information that we don't have access to. So this kind of explains some of the differences between fee-for-service claims data and managed care encounters. With fee-for-service, we have that direct record of a bill was sent and a payment was paid. With managed care, we are relying now with encounter data on the managed care plans to collect information from the providers on what was done, and then they send that information on to Medicare. And we'll talk a little bit about that in the next segment. And then that's how the encounter data arise. So when we talk about how managed care is kind of maybe limiting care a little bit, you have to have a primary care provider, and you have to, maybe go through utilization review or some of those things. Managed care plans do provide everything that's covered by traditional Medicare, and oftentimes they will cover even more. Some of those things that were not covered by traditional Medicare, so the vision screening, excuse me for the typo, hearing screenings, maybe eyeglasses, and they also can offer reduced copayments or deductibles for beneficiaries and annual out-of-pocket limits and some pharmacy benefits. So it can be very attractive for an individual to say, well, maybe I'm going to try this managed care plan because I'm going to get all of these extra services. If we look at managed care enrollment, we're going back to the beginning of our data in 1999. You've always been able to look at Medicare managed care enrollment in the master beneficiary summary file, but we haven't had the encounter data until 2015. But anyway, looking at our data, you can find that managed care didn't really, it was, 18% or so, and it was dropping until 2003 when it took off. Does anyone have a guess as to why it maybe started taking off in 2003? Yeah, so there was a policy change, the MMA, that happened. So it actually doesn't really, maybe you're all wondering why I'm saying 2003. It doesn't really rise until about 2006. The MMA was passed in 2003, and most of the provisions happened in 2006. Right, and Part D was brought up here. So in 2006, based on the MMA of 2003, the Part D was added. Now, Part D means that Medicare beneficiaries can receive prescription drug benefits through Medicare. If you're enrolled in original Medicare, you will, and all of the prescription drug benefits are administered by private plans, similar to Medicare Advantage. But if you're in original Medicare, you will enroll in a standalone prescription drug plan, private plan, and you don't have to enroll in Medicare Part D. There are some penalties if you don't enroll when you're eligible and then you enroll later. But you do have the option in original Medicare. But the Part C plans typically, now it's not 100% of the time, but typically they will include Part D benefits within their plan. So if you're a beneficiary, you might be looking at the plans and saying, well, I get this Medicare Advantage plan, I get Part A, Part B, Part D. In addition, because they have so many different service lines going on, but Medicare Advantage plans can often subsidize the Part D, reducing the premiums, sometimes they can provide, coverage where the standalone prescription drug plans weren't doing so, like in the coverage gap, which was kind of a creation of Part D. So that might be another reason why beneficiaries started enrolling in the Part D plans. The thing to remember about Medicare is that all of the Medicare program is congressionally mandated. And so in the Balanced Budget Act of 1997, that's when we had the Medicare Plus Choice. They added some provisions. And then in the MMA of 2003, there were a lot of, there was the addition of the Part D program. There were some other incentives. They changed the payment structure for Medicare Advantage providers. The reason that I bring this up is that, like with the Part D piece, if you're plotting things over time, it's really good to kind of look back at what's going on in the legislation that may or may not influence what you're seeing, because that might change the population that's enrolling, or it might explain some behavior. Now, where are we now? In 2021, we have almost half of the population is enrolled in Medicare Advantage, which is a big difference from that less than 20% we saw at the beginning of the 2000s. Depending on how you measure it, it can be closer or farther from half. I think now in 2023 or the 2024, they say it's even closer to half. It may have even edged out fee-for-service a bit. In this case, we're measuring it as those continuously enrolled in HMO or fee-for-service parts A and B. So because we have monthly benefits, you kind of have to decide how you're going to measure things, which is one of those analytic decisions we have to make. When we talk about Medicare Advantage, we're not talking about a monolith. There are many different kinds of plans. The coordinated care plans are the most common. So this would be a health maintenance organization. It could have point of service options, or provide preferred provider organizations, which could be local or regional. And that was one thing that expanded with legislation. The ability to offer regional plans happened, I think, in 2003. And that means that a plan could, not just contract with small providers, but it was really a way to get more rural beneficiaries the option of enrolling in Part C. So the regional plans are they're very common now. There are provider-sponsored organizations as well. And then there are other types of plans, like the program of all-inclusive care for the elderly. This is all-inclusive coordinated care designed to help elderly beneficiaries stay in their homes. So it will, provide home health services and daycare, adult daycare, and many different things. But it's not a huge proportion of the MA overall. There are even Medicare medical savings account plans. Again, not the most common plan and not the most not the highest enrollment, but these would be similar to the high deductible health plans that maybe you're offered in your employment. So you have a high deductible health plan and a health savings account that you can use. There are also private fee-for-service plans. They have, different types of administration and payment schedules than our Medicare fee-for-service. Again, it's not a lot, but we do have some. So how does a beneficiary decide which one of these plans they want to enroll in? There is this Medicare Plan Compare that they can go to. You type in your zip code, because not everyone in the United States has the same is offered the same suite of plans, because these plans might operate locally or regionally, and within states, then they, a different person may have a different suite of options. If you go to Plan Compare, I would encourage you to do it and kind of check it out. Like, how would you decide which of these plans you want? It will tell you like what are the benefits offered. You can even type in what drugs you're taking, and then they'll give you information about how what your fee structure would look like for paying for those drugs. So it's very interesting, but it's also a lot of information. So it can be a lot for someone to try to wade through and figure out, do I want to enroll in one of these plans, or do I want to stay with fee for service? So there are also things called employer group waiver plans. These aren't separate from the plans I talked about. Some of those plan types are going to be included in here. So we have about 1,400 EGWIP plans, is the way of saying that, EGWIP. And about 18% of MA beneficiaries are enrolled in EGWIPs, and these are provided by employers to their employees. So the employer will contract with the Medicare Advantage plan, and they will offer a plan just to the employees. So it doesn't have to be open to everyone in the region. And they have different, you don't have to enroll during the open enrollment period. You can do it whenever you retire, for example. You might enroll in the EGWIP. So it's not an insignificant number of beneficiaries that are enrolled there. There are things called special need plans. So dual eligible special needs plans are a type of plan to meet needs of dually eligible beneficiaries. And what I mean by dually eligible is that they're eligible for both Medicare, or because they're elderly or disabled or have a condition that qualifies, and they're also eligible for Medicaid, which would be a state administered program, and that they may be eligible because of income or special needs, like a disabled child or something like that. So in that case, someone can enroll in a special needs plan, in which case, where their Medicare and Medicaid services are covered by the same plan. And this, they started in 2006 and then permanently authorized in 2018. And they operate in 45 states, and 3.8 million dually eligible beneficiaries are enrolled. But they're not the only kind of special needs plans. There are also special need plans that are condition specific. So maybe they're for patients with diabetes or something like that. And then there are some that are institutional special needs plans. So someone who is using long-term care, they're in a nursing home, they can get a special needs plan as well, depending on if it's available in their area. But the most common are the dual eligible SNPs. So SNP is the other way of saying special needs plan. I know that there's been interest recently. There are things called fully integrated dual eligible plans and highly integrated dual eligible plans. So it is a huge area. So if we look at managed care and fee-for-service comparisons over time, we thought that we were going to show lots of differences, but we haven't actually found that. So we just have a couple of slides for you. If we look at the mean age, we do see, slight differences in fee-for-service and Medicare Advantage over time, even over all of the, enrollment increases. We can see kind of a change here. That's in that 2006 area where plans were really revving up with their Part D. But by and large, we have very similar ages. We do have differences in the percentage non-Hispanic white over time. It used to be much more similar and now has definitely changed, or it's separating. The fee-for-service is much higher percentage of non-Hispanic white than the Medicare Advantage plans. And part of that might be where the plans are operating in terms of geographically, but we'll talk a little bit more about that. Current snapshot of the Medicare Advantage population, and from 2021, which is the most recent final data that we have, you can see there's definite geographic variation in Medicare Advantage enrollment. Minnesota, where I am, we have pretty high Medicare Advantage enrollment, but there are states in, mountains where there are relatively few people enrolled in Medicare Advantage. It's even more that the state picture, I guess, kind of masks the county picture. A lot of the plans are local or regional. They're not going to be maybe statewide. And so you will find that even in Minnesota, where we have a high percentage of people enrolled in Medicare Advantage, there are still some counties that have, much lower enrollment. And that's true, all over. We have kind of cities. When we look at Wisconsin, we have kind of Milwaukee and the Fox cities have a lot versus the rest of the state. In the South, we also can see kind of the same patterns in Florida. And in the West, there are lots of counties where there's very low penetration, but then there are these places where we have higher and higher penetration. And I always think of California as being a very heavy HMO using state, but it is definitely, there are differences by county. If we look at the current reason for entitlement, there are some differences. So people with disability benefits are more likely to be enrolled in Medicare Advantage, and the aged are more likely to be enrolled in fee-for-service. State buy-in would be another way of saying a dually eligible beneficiary. So it's called state buy-in because the state will buy into the Medicare program on behalf of the Medicaid beneficiary if they're eligible. We do have slightly more Medicare Advantage use among people with 12 months of state buy-in. And that, could be partially with the dual special needs plans, the dual eligible special needs plans, the DSNPs. Oops. And again, this is just more of a breakdown of the race. We had seen before that Medicare Advantage plans have more diversity in terms of who they're serving, especially with Black beneficiaries, whereas fee-for-service has more non-Hispanic white beneficiaries. So when we think about Medicare Advantage, we know that Medicare Advantage enrollment has increased substantially over time, and it varies by geography. So these are things to keep in mind as you might want to plan a study. But overall, the key demographics, eligibility, use of related programs is pretty similar between MA and fee-for-service. Before 2018, we actually didn't have any data on Medicare managed care. So now we have data back to calendar year 2015, but they weren't actually released until the year 2018. And so we have now the ability to look back to 2015 for Medicare Advantage, but that never used to be the case. It used to be that you didn't have any information on managed care enrollees in the claims files, except hospice. Hospice is a carve out, so we'll talk more about this later, but if you want information on hospice for managed care enrollees, you will get the fee-for-service hospice file because they've always been included in that file just based on the way the program was designed. The MedPAR we'll also be talking about later. That's another one where we maybe had some information on managed care enrollees. Researchers have usually, in the past, before we had Encounter Data, limited their fee-for-service studies to people likely to have complete claims, meaning they had equal months of Part A and Part B, so we felt confident that we would see all of their healthcare use, and they had no managed care, because if they were in a managed care program, then we wouldn't be able to see their use. But now we have Medicare managed care encounter data, and so we can look at, how are managed care beneficiaries using different services. We can attempt to combine the data with fee-for-service data, original Medicare, to get a more comprehensive view. And we can compare managed care and original Medicare, or we could look at different plan types, how they compare to each other in terms of use. I'm just going to do a quick look at this just because I had given you the schematic of how Part A and Part B and Part D are designed. And we've talked a little bit about how the files have become available. So right now we have fee-for-service data back to 1999. Oops. And If you're interested in Part A use, you can get home health agency, hospice, inpatient, skilled nursing facility. If you're interested in Part B, there's the carrier, durable medical equipment, home health agency. So it's one file, but it includes Part A and Part B services because there are different services covered under Part A and Part B for home health. But we also have the outpatient file, the hospital outpatient file. For the encounter data, we have, it's very similar in structure. You'll notice under Part A, we don't have hospice because that's just one file that includes MA. But otherwise, it's set up very similarly to the fee-for-service data. Part D, ever since it has become available in 2006, it contains both fee-for-service and Medicare Advantage in one file if you ask for it. So there are lots of different files available. There's, the prescription drug events, which is, actual fills, but then there's information about how formularies are designed, the characteristics of pharmacies and providers. And then there's a plan characteristics file that has been available since 2006, but prior to, or it never used to have, I should say, it never used to have in 2014 and prior, it didn't have Part C information, but now the plan characteristics file does. So Becky will be talking a little bit about that later, how you can find more Part C or more information about the plans themselves.